Thank you for inviting me. Make sure I know how to work this. I really am excited to be here today. Make sure everyone can hear me a little bit better. This is actually unique and welcome audience. I usually speak to clinicians and researchers specifically and talk about science and data. And today I get the opportunity to talk to people who are really the recipients of that science and data and talk about how we make this important in our lives every day. So just kind of as a beginning, and let me make sure this works here, Christian, to move that forward. I always like to have a few disclosures. So I'm very proud actually to work for ThermoFisher Scientific, which is a leading manufacturer of diagnostic tests, lab equipment, and specifically we focus on the management of infectious diseases. Also, I think it's really important to understand from an industry perspective what we do in this area to create value. And ThermoFisher is participating in a coalition of multiple, and I think it's 4 other major diagnostic companies that are committed to fighting infection and C. difficile, and I'll talk about that in a minute and just exactly what that means. Now, when I was doing these slides and tweaking them about midnight last night, I had a couple personal disclosures on there. And then this morning, they didn't. I thought, well, maybe I should take them off. But I think for this group, it's important to know a little something also about me. I practiced for 20 years in the critical care environment and have delivered thousands of doses of antibiotics. It doesn't really keep me awake at night, but I have thought about that many times. At the time you are practicing and when you give those, you think that you're giving them for the right reason and for the right purpose and for the right duration. But we have learned so much in the years that I've practiced. And I think that's important, and I'm so excited to see the advances in science and the advances in managing patients. Another disclosure is that as much time as I spend talking about antibiotics and appropriate use of antibiotics, I recently refused to take antibiotics for a dental procedure, and I now have a somewhat awkward relationship with my dentist. So you do have to be a little careful how you apply the science. He said I was proceeding at my own risk, and I'm still here today, so I think I made the right decision. But you know, you do think about those things as well. My last disclosure is I also have a fascination with Wonder Woman, Christian. And anytime, give me a call because there are many races, I think that there are 5 10Ks and half marathons that are Wonder Woman races all over the country, and I would be happy and proud to run in one of those with you, and you do get to wear the cape and carry the lasso. So we could do that. Let me go backwards just a minute here. So the objectives today are several-fold. One is to make sure I can get this clicker to work just right. But what I really want to do and hope you walk away with is that you understand and have some awareness of the value that diagnostics really bring to management of antibiotics and making sure that they're used effectively and for their best patient outcome. And then also to connect this unique opportunity that's really currently available in the diagnostic field to help prevent adverse reactions from antibiotics, one of which, of course, is C. difficile. And that's something that I think is maybe just a little different perspective when Christian and I were talking about what I would talk about today. We talked about how much emphasis is put on developing diagnostics to confirm and diagnose infections, and those are so important. If we don't know what we're treating, sometimes, we're really working in the dark. But what sometimes is not really talked about is how can we prevent, how can we use diagnostics to make sure we're giving the appropriate duration of antibiotics and therefore minimize the risk of developing resistance and developing adverse infections or opportunistic infections like C. difficile. And then thirdly, I want to talk about how ThermoFisher specifically is really aligning with federal agencies and with advocacy groups such as Peggy Lillis Foundation to fight against infections, C. difficile, and antibiotic resistance. So when Christian said, what do you think about the title of your talk? So it's using diagnostics to drive antibiotic stewardship. And I'm like, fine, that sounds great. Then when I started putting my slides together, I thought, I don't know. I love a good analogy. I really do. I taught in healthcare, critical care nurses, for quite a few years before I actually left the hospital setting, and analogies are the backbone of healthcare education. It makes things come together for people. But I think that I would change the title of this talk. So at the end, you tell me if you agree with me. But really, I think when you talk about a driver, you're talking about a person. You're talking about people who have the expertise and the knowledge to apply the tools that they have for the best purpose. So I would actually say that diagnostics is not the driver. The driver are those people on the antibiotic stewardship team that really make the decisions, that use the data, use it to its best purpose. However, I think what I would say is that diagnostics are perhaps that navigation system. And, you know, as someone who travels about 75% of the time and really never knows where I am, actually, I'm pretty reliant on GPS. I don't know about some of you, but I started traveling around 2004 before GPS was out. And so before I'd go on a trip, I would actually MapQuest every potential place I was going to go, from this hospital to this doctor to this hospital to that hotel to this airport, print them out. And it never failed. You went somewhere you weren't planning on, right? And at that point, you were using that little 2x4 Avis map, trying to figure out where you're going. So I'm a fan of GPS. And I like Waze. I like Waze because it's that real-time, you know, feedback from the feet on the street, as it were, that are telling you where that pothole is, or where there's a dog on the side of the road, or where the radar trap is. So really, I would say that diagnostics are that navigation system. So last night I thought, or actually this was the night before last, I was in Boston at an advisory meeting. And I thought, well, what if I really decided not to fly to D.C. and I just got in a car and drove? Well, probably didn't really want to do that. But when you look at this, think about what this tells you. I can see that there's multiple radar traps, that there's all kinds of road issues. But if everything was perfect, I would have got here in 6 hours and 45 minutes at driving 445 miles per hour. You see that the only address I know in D.C. is the White House. There's a story behind that I have to tell you later, and a patient who actually told me their address was the White House, and I put it in their chart. This is in Southwest Missouri. Didn't pick up on that until it was actually in the healthcare system, and it took me a while to live that down. I said, didn't you recognize that? I'm like, no, I didn't. But the thing is if everything was perfect, you'd get here, you'd follow those exact directions, you'd make a left turn on this highway, you'd make a right turn on that highway, and you'd be where you wanted to be at the end of the road. But that's not the way it is taking care of patients. There are roadblocks, there are potholes. We do have problems with dealing with resistance. Not every patient responds to every medication in the same way. So diagnostics can really give us that kind of information to help us understand what is the right drug, what is the right dose, how long should we give it, what should we be looking for in outcomes. So I probably rename this talk using diagnostics to navigate antibiotic stewardship. I don't know where I'm supposed to be pointing this. Up, down, down. There we go. Okay. So first of all, I think that I'm probably speaking to the choir that we all think that antibiotic use and whole, we should be somewhat alarmed. But a lot of times what I'm really looking at is scientific data, and I'm looking at research. And when I was putting this together, I thought, I want to look and see what the average person sees in the media related to antibiotic use. So I thought, well, I'll just Google New York Times and antibiotics. And this is what I found. Within the last 3 weeks, there was multiple papers or multiple editorials, but I just thought, this is what people are seeing every day. And no wonder there is some panic about antibiotics. Sometimes not enough panic, I think, because people still really want antibiotics when they go to the doctor. Pretty much every time. If you take that effort to go, don't you think you should walk away with something besides you need to drink fluids and go to bed and rest? That's really pretty common in all of us, I think. But the first one I saw was from March 15th, and it said, older Americans are awash in antibiotics. Told a really normal but poignant story of a 68-year-old woman who went and was just given an antibiotic prescription, was really not given information about it, what her risks were, and it talked about that's the common everyday occasion that's really going on, and it's very prevalent, especially in the older population, who are really more at risk for C. diff, they're more at risk for resistance, they're more at risk for having many adverse events that are tied to inappropriate antibiotic use. And then the second one was talking about a fungal infection that's resistant, and it's talking about Candida aureus, and I thought that was really alarming, and a lot of people are not that aware that it's not just bacteria that are becoming resistant, it's also fungal infections. So in this data, it said that as of 2010, the CDC reported that antibiotic resistance in the U.S., that there's about 23,000 deaths. But more recently, and this comes from Washington University School of Medicine, put the death toll at something like 150% in over a 9-year period. It estimated at 162,000 with worldwide fatalities at almost 750,000. So I think we should be alarmed. We should think, what can we do better as far as appropriate antibiotic use? So, these are important, but I would guess that the majority of you are here not because of necessarily something you saw in the New York Times that said, you know what, we're being overcome by fungal infections that are resistant, or our elderly are at risk for inappropriate antibiotic use, but it's because of something you experienced personally. And, Christian shared his story. We've had other stories shared already with the speakers, but I think every one of us, if we haven't been impacted by inappropriate antibiotic use or even appropriate antibiotic use, we will be at some time, and it's personal to each of us. And this is something that's very personal to me. This is Emma. She is my very best friend in the whole world's mother-in-law, and she passed away a year ago, December, following a protracted illness with C. diff. She had she was a very healthy 76-year-old woman. She lived in an independent care facility. She rode every bus that went to every play, went to Branson, Missouri. She loved to fish. She loved to go to ball games. She loved to eat Mexican food. That was her favorite. And Emma was a part of my life. She was at all our kids' ball games. She was a lovely, lovely person. And she developed a urinary tract infection and got antibiotics, didn't get better, got more antibiotics, kept presenting to the emergency room, developed severe diarrhea, which wasn't identified immediately as C. diff, and they were never able to really clear her C. diff. So over the course of about a year, she progressed to being weaker, sicker, being in the nursing home. They switched nursing homes because they felt like maybe if they could just switch her environment, they could clear her C. diff. And ultimately, she died of renal failure. Her system failed. She developed sepsis, renal failure, developed heart failure. So I think on her death certificate, it'd probably say she died of renal failure, but Emma died of C. diff. She died of multiple organ failure as a result of an inability to clear that infection that just made her weaker and weaker, and her immune system finally failed. So we miss her every day, and this is actually her daughter, Brenda, who would call me almost every night and say, "Mom's slipping away. What am I supposed to do? What can I do? Tell me the questions to ask." They'd never heard of C. diff before. When I called and asked them this week, "Can I talk about Emma?" they were thrilled. They really didn't understand or know that there's an advocacy group for C. diff, but now they do, and they're thrilled. And I think that they would be a family that would be so invested in the same goals as the Peggy Lillis Foundation. So that's kind of my personal, and I think we all have that personal. Even those of us who work in the industry and work in the business, it's still personal to us. So I think that from some of the questions, there's obviously that antibiotic stewardship is one of those terms that just gets thrown around, but people don't know exactly what it looks like. So actually I do know what it looks like from a personal level, and then also from every day. I have a team of 8 medical science liaisons that's their goal in life, and every day is just to engage with clinicians and with the sepsis teams and with the antibiotic stewardship teams to talk about how they can best utilize diagnostics for the optimal medical value to enhance patient outcomes. So all they do is education. They're not a part of our commercial team at all. And so when you talk about antibiotic stewardship, I looked up stewardship just because I'm just a nerd and I like to look things up in the dictionary. And I want to know, what is the definition? I don't know what we did without Google. Do you? Before? How did we live? I don't know. But it says that it's conducting or supervising or managing, especially something, the careful and responsible management of something that's entrusted to one's care. And I would say that I believe that these medications that are life-saving are trusted to our care. And this process is entrusted to our care, and we need to take it just that seriously. But when you talk about antibiotic stewardship, even back in 2001, this was being talked about. And I really like this definition. It talked about the optimal selection, dosage, and duration of antimicrobial treatment or antibiotic treatment that results in the best clinical outcome with minimal toxicity, so we're not actually poisoning our patients, we're making them better, and really doesn't increase the resistance to these medications. So when you think about it, it's doing the right thing at the right time, and it's a balance. It's a fine balance, and we do need antibiotic stewardship processes to make that happen. This is not intuitive, and it doesn't happen organically. I will say that, and I believe that firmly. So when you think about antibiotic stewardship, let me just talk for a minute about really what it looks like. There's a team, and this team has to be multidisciplinary, and they need to meet on a routine basis, and they generally meet, what I see is usually once a month. Some of them meet every other month, but they have to be represented by the people with the right expertise to identify what is the best standard practices that we can put into our hospital and how can we have the best patient outcomes. So you have to have someone from the laboratory there, and that's important to represent. They understand diagnostics, they understand what it can do, how it can help. You have to have someone from infectious disease, you need to have someone from the emergency department, you need to have someone from probably the hospitalist group, maybe the intensivist group in critical care. So these people all bring a very distinct perspective and expertise to this process and how to decide what's the way we want to manage these patients. But really, I think almost most importantly, it needs to have a representative from pharmacy. And I firmly believe that antibiotic stewardship is a specialty within a specialty. And when you talk to pharmacists, they will tell you not every pharmacist really has the expertise or works in the environment to understand the laboratory test, to understand how to apply the best prescriptions to the patients, how to understand what the resistance patterns means, what's the community antibiogram, what are we seeing out there as far as bugs and what's working. So they really need to have a pharmacist that leads this process, and I think that they are the person who really has that overall expertise. But their goals are really fourfold. One is to personalize treatment, and it's important to look at population data. We've looked at a lot of population data. We just looked at some that said, 162,000 people are developing resistance to antibiotics. But what they really want to do is say, what about that one patient? Because population data is important, but even more important to me is how I'm going to respond to an antibiotic, or how my mom's going to respond to that antibiotic, or how my child is going to respond, for a prescription for pneumonia. So that's what's really important, is personalizing that treatment. And that treatment we've talked about already is the right drug, it's the right dose, it's the right duration. And I will make just a comment here. From a healthcare perspective, almost everything we do in treatment as far as pharmacologic treatment is what we call titrated to effect. In other words, if you go to your physician and he says, you know what, Sherrie, your cholesterol is elevated, and that did happen, I have to say. So I can use myself as an example. I have a strong family history of heart disease and hypercholesteremia. It was elevated in my 20s, and we had a lot of conversations about, whether I should take anti-cholesterol medication. And I didn't want to, but I did eventually. And so what they did was they drew labs, right? They got a lipid level. They got a lipid panel. They looked at my HDL, my total cholesterol, my triglycerides. They prescribed the standard of care cholesterol medicine. And then guess what? They said, you need to come back. You come back in 6 months, we'll redo your lipid panel, we'll see if we are giving you the right dose, because this is our target. We want your total cholesterol to be under 200. We want your LDL to be under 130, but we'd really like it to be under 100. And we'd love you to get your HDL up above, say, 50, 55. And you know what you need to do for that, don't you? Exercise. That's always a popular treatment application. So, in other words, they didn't just blindly give me a standard dose. They checked my blood levels, they gave it, then they came back and they checked it, and we titrated it. They adjusted my levels. And we do that every year. In fact, fortunately, I was able to go off them because I took the eating right and exercising to heart and did a good job with that. But what about people who have high blood pressure? Do they just give you an ACE inhibitor or a beta blocker and say, go out, enjoy your life? Your blood pressure is high. That's pretty much of a risk for, poor outcomes. You might have a heart attack at some point, or you're higher risk for heart failure. But this is what we generally give because, in large population studies, this is the best dose. Is that what you do? No. They say you need to come back. Come back next month, we're going to recheck your blood pressure, or we're going to send you home with a blood pressure cuff, and you're going to take your blood pressures every day, and you're going to call us and tell us what they are, and we'll adjust it, and we will personalize that dose to you. So that's what I mean when we say that everything we really do in pharmacology is titrated to effect, except for what? Antibiotics. What do you get if you get a Z-Pack? You get 5 days. If you have a certain type of infection, it's like, this is a seven-day course, this is a 10-day course, this is a 14-day course, and we now know that that is not appropriate. That is not the most optimal use of antibiotics. There are ways to say, how are you as an individual going to respond to that medication? And can we minimize the exposure and therefore your chances of developing adverse reactions or adverse effects such as an opportunistic infection? So sort of my soapbox for personalized medicine, but I believe in it pretty strongly, and I didn't mean to go forward quite that fast. There we go. So I hope there's not like something on the evaluation for electronic ability, Christian. I am married to an IT guy, but it's not an osmotic kind of expertise. Just sleeping in the same bed evidently doesn't rub off using electronics. All right, so there you go. So appropriate use, and that's overuse, misuse, and abuse. And I do want to, there was a great question in one of the earlier discussions about worrying that patients will have antibiotics withheld when they really need them. These are life-saving medications. They should never be withheld. Antibiotic stewardship is as much about saying who needs antibiotics and how long should we give them to them and at what dose to make sure they recover, as it is about making sure that we don't give them inappropriately. So when we talk about appropriate antibiotic use, it's about making sure people get the antibiotics they need just as much. And diagnostics are very useful in identifying that, not only in who needs them initially, but maybe which ones to give, especially when we start getting sensitivities back and resistance back. We talked earlier about de-escalation. De-escalation means narrowing the spectrum. We don't need to give those broad spectrum antibiotics. It's like bringing a machine gun to an ant fight. And we also don't maybe need to give them as long to some patients. So de-escalation is very important, and it's very much supported in diagnostics. And then we talked about already minimizing adverse events. And that is opportunistic infections, that's allergic reactions, that's resistance. There's many things that we really have as a goal of antibiotic stewardship, and finally health economics. And for our purposes today, I really don't have time to talk about health economics, but that's not just the cost of a prescription. This is the cost of caring for patients who have adverse events occur. And it's very costly. It's costly to us as a family and as a person, and it's costly to our healthcare system. So when we talk about antibiotic stewardship, there's 7 core elements. And I'm not going to talk about all of these. I'm going to talk about the action piece. And I purposefully left that big open area there because the core elements are all important. You have to have leadership at your top level. Your leaders in your healthcare system have to support it with funding and with resources and people. You have to have someone that's accountable, and I would postulate that accountable person is that antibiotic stewardship expert in pharmacology, that pharmacist. You also need to have an action, and then you need to say, did it do what we want? Are we getting the results we want? And we needed to report that. It's important because when people have to report, they're much more accountable. And then we need to educate people. This is the best thing. This is a best practice. This is what we need to do. But what about that action? That's a huge opportunity. And the CDC actually gave one example of an action. So in the core elements, they say you have to give at least one action that you're working on. And the example they gave was implementing a systemic evaluation of ongoing treatment need after a set period of time, such as an antibiotic timeout after 48 hours. Now, I want you to keep that 48 hours in mind because I just found a very new study that looked at using antibiotics for 48 hours, less than 48 or greater than 48. So this is just one example, but can you see where diagnostics can help with understanding the best actions and then being able to measure how they perform? So these are the core elements, but moving beyond that, someone mentioned, the first speaker I think from Pew mentioned PAC-CARB, and that there's a meeting. I don't know if she mentioned there's a meeting today. So many of you are probably aware that there's a Presidential Advisory Council on Combating Antibiotic Resistance that was initiated several years during President Obama's presidency. And this is a very active group. They meet about 4 times a year, and they look at both human antibiotic use and they look at animal antibiotic use. And very interesting to attend these meetings and see that they really drive practice. However, what's I think important for you as a group to understand is they today at noon are meeting, and this is a mid-cycle meeting, which is very unusual, to talk about the potential expiring of the participation for antibiotic stewardship. They're very aware that if this is not finalized, this recommendation or rule is not finalized, that hospitals need to have an antibiotic stewardship program. By June, it will expire, and like you heard this morning, that will highly extend that process. And we believe that process is very important. So at noon, they're meeting, and they're going to give recommendations back to Medicare, CMS, on that process. And what they say is that this rule requires the adoption of antibiotic stewardship in hospitals, and it's really important to help reduce the daunting overtreatment of patients with broad-spectrum antibiotics and improve the care of patients. So we should be seeing something from that after this afternoon's meeting. So what does ThermoFisher, what do we believe? Well, what we believe is that antibiotic stewardship committees play a vital role in combating antibiotic resistance and ensuring the best possible outcome. And this is firm within our belief and how we practice in our business practices. We also believe that these antibiotic committees and policies are in the best position to monitor and evaluate the performance of treatments and also new types of treatments and diagnostic tests. And these diagnostic tests include not only pathogen detection, but also the identification, but also FDA-approved tests for the management of sepsis and discontinuation of antibiotics when they're no longer necessary. We also believe that the proper use of available diagnostic tests is right now the easiest and quickest way to support antibiotic stewardship programs in the healthcare system. And we believe that there is a lack of awareness of what is available and what can be leveraged now, not to discount the importance of developing and evolving diagnostics and treatments, which are very important. We should never stop moving forward, but we need to leverage what we have available now as well. And we support the implementation of antibiotic stewardship committees and other Medicare efforts in addressing this national health issue of infectious disease. So diagnostics, in infection, there's really three things they do. One is they identify the bug. It's important to know what is the microorganism you're working with. And there's many different diagnostics that do a very important job. We mentioned blood cultures. Of course, there's challenges with blood cultures. They're not always able to capture the microorganism, and they do take some time. So there's a lot of really interesting work in developing new diagnostics for microorganism detection and identification. And then there's really important perspective of diagnostics that is identifying susceptibility and resistance. We need to know we're giving the thing that will work. Then thirdly, there's the host response. And this is the area that I work in on a day-to-day basis. And let me just clarify this. What is a host? You are the host. You're the person getting the antibiotics. Your mother's the person getting the antibiotics. Your kid's the person getting the antibiotics. And this means there are diagnostics that can say, how are you as an individual responding to that treatment? Are you getting better? Are you not getting better? And can that guide our decisions on antibiotic measurement and how long we should give it, and whether we should look for another cause for illness, whether we should look at another type of antibiotic, because one isn't working. So as far as the prevention of C. difficile, is there a gap for diagnostics to work within? And I'm not going to go over these in detail because I pretty much feel like this is a group that probably has memorized these. But what I will suggest is that there is a gap to fill, because these prevention and important prevention tactics are really directed at identifying C. difficile, important, confirming it, important, containing it, important, and then also looking at the antibiotic appropriateness of the treatment. What are the high-risk antibiotics for C. difficile? Can we look at other types of antibiotics? But there's really nothing in there that says, are we looking at minimizing the duration of the antibiotic in a safe way? And I think that's the gap that we really are looking for, from our perspective, to say that there is an opportunity within C. diff prevention for diagnostics that's really not reached a level of awareness that it needs to. So when I talked about 48 hours, let me go past this here real quick. I do love data, and I'm not going to bore you with this data, but I'm going to make it just really personal for you. So this is a study I just found. It was published in October in the Clinical Infectious Disease. Really interesting. This is a study that came out of North Carolina where they took 800 patients and they looked at them. And all these patients came in. They were in the hospital for at least 2 days, and they were all in for a bloodstream infection. So they looked at the patients who got antibiotics for less than 48 hours, and they looked at the patients who got antibiotics for greater than 48 hours, and they said, when did these patients develop C. diff? The ones that developed C. diff, was there a difference in the duration of the antibiotic exposure and the risk of developing C. diff? And what they found is that early de-escalation of the antibiotics, also using a clinical risk assessment score. Remember, there's always a driver. This is never done. Diagnostics never function in a vacuum. They are within the environment of care and the context of care, just like our GPS, only gets us to the place we want to be in the time we want to be if we take into consideration the context. Is there a radar trap? Is there road work? Is there a bridge out? All those sorts of things. But early de-escalation may reduce the incidence of C. difficile infections in hospitalized patients. And I'll show you a picture that I think speaks even louder than this slide, which is pretty busy. But this is looking at a rock curve. And so what you see on the vertical axis is the proportion of patients that develop C. difficile infections in these 800 patients. And along the bottom, you see the number of days out to 90 days. And when you look at this dotted line right here are the patients who received antibiotics less than 48 hours, and this black solid line are the patients who received antibiotics for greater than 48 hours. So extended antibiotic exposure, minimized antibiotic exposure. And what you see is the rate of C. diff within these two groups. The difference is 7% in this group and 1.8% in this group. And this p-value, as you see, is 0.002, which is extremely statistically significant. So I think this is just really good real-life data to show that we can make a difference in minimizing and appropriately minimizing antibiotics in the risk for C. difficile. And diagnostics can help with that as well. And I'll show you, the next slide I want to show you is actually a study that was done in Pocahontas, Arkansas. You cannot get more real world than Pocahontas, Arkansas. Has anyone ever been there? You have? Oh my gosh, I've hardly ever had anybody raise their hand. I've been there too. It's a big place, right? Big place. But they have one of the most progressive pharmacists that I have ever met. His name is Mike Broyles, and he has published a lot of data, and he is an early adopter. I love early adopters. Those are those people that say, there's got to be a better way. Let me see how I can do it. Is there data to support it? They're not people who do things willy-nilly, but they look for strong data, and they're willing to take that risk, and they're willing to fight the currents within a healthcare system that want to keep things the same, which, it's easy. Status quo is easy. We all know that. But Mike Broyles, he is not a status quo guy. He's an amazing guy. And he he felt strongly that every patient that received IV antibiotics in his hospital deserved an objective way of evaluating how they were responding to it and getting an appropriate dose. So I have to tell you, this is a county hospital. It's pretty busy, but it's small. It has a nursing home attached, not physically, but next door, so they get a lot of elderly patients as well. And so he started using a host response diagnostic several years ago, procalcitonin, which elevates very specifically with bacterial infection, not viruses and not fungal infections. And it goes up in response to the amount of bacteria. It's very prognostic for how sick this patient is or how sick they're going to become, how quickly. And if you effectively treat them, it comes down in a very consistent way. So it has a half-life of 24 hours. So if you're really managing source control, as pharmacists call it, meaning that you are effectively treating the microorganism, then you should see that measurement would come down about half every 24 hours. So he started using some algorithms that were published and validated in Europe for many years, but he was an early adopter for sure in the U.S. And so he looked at his patients over a 9-year period of time. He took 4 years before he started managing his antibiotics in this way. Then he had a 1-year washout, and then he took the 4 years after and said, I want to see if there was a difference in certain outcomes in these patients in response to how we changed our treatment of these patients. So what you see are these the patients, about 1,000 before, when they were just using a standard of care, and this is about 1,000 patients afterwards, about 4 years afterward. And what he looked at, his primary thing was, he said, I want to see how many antibiotics they got. So in pharmacy talk, they talk about days of therapy. For lay people, that doesn't always make a lot of sense, because when you look at 17 days versus 9 days, you're like, why are they giving antibiotics for 17 days? They're really not. You would count. So if you got 3 antibiotics for 2 days, that's 6 days of therapy. Does that make sense? So it's not actual days, it's how many antibiotics times the number of days they got, that number of antibiotics. But what he said is I want to see, does it really impact the exposure to antibiotics in our patients? And what he found is that there was about 8 days of therapy less. And again, that's not actual virtual days, but it's significant that they had much less exposure to antibiotics. But secondarily, he said, I want to make sure that we're not doing these patients any harm, and this is always important. So he looked at mortality, he looked at hospital readmission, and he looked specifically at C. difficile and then other adverse drug events, and these would be things like allergic reactions and those types of things. And just to point out a couple, the C. difficile, over these 2 time periods, he saw a 1.6% reduction. So in the time period before, in those 985 patients, they had 25 cases of C. difficile. And in the time period after, in 1,067 patients, they had 10 cases of C. difficile. This is significant. You realize this doesn't look like a lot, but when you're that one person in 50 that doesn't get, or that does get C. diff, is that important to you? Yeah, absolutely. I think anyone who's ever experienced C. diff would agree with that. And then, of course, he tied this back and feels strongly that it is a direct result of their decreased exposure to antibiotics. So that's all the data I'm going to show you guys. I know you wanted to see a whole lot more studies, but we're not going to do that today. We're just going to end up, and I'm going to talk about, I mentioned at the very beginning that ThermoFisher is part of a coalition for best practices in managing sepsis and antibiotic stewardship. And what does that mean? And what that means, and what our mission in this coalition with 4 other major diagnostic companies is, we strongly support federal initiatives to deal with the crisis of sepsis, infectious disease, and antibiotic stewardship. We are engaging with these agencies this week and actually on an ongoing basis. They've been very open to this. We know that many of the government agencies are working on these issues, and they've generally been very open and welcoming to having input and having more understanding and how diagnostics can help these initiatives. We also, as part of this, understand that Congress recently asked the Medicare to report on its efforts to fight sepsis and use diagnostics to monitor infections specifically. We're really looking forward to that report, and we know that Medicare is prioritizing this and is always looking at a way to improve its policies. I've already mentioned that at noon today there's a pretty significant discussion with the Presidential Advisory Council on antibiotic resistance. We're very eager to understand what comes out of that, and we certainly hope that there is a strong support to continue and finalize the participation for antibiotic stewardship in hospitals. And we really continue to hope, and we feel very confident that CMS will be open to public input. And our vision is that they would actually host a public conference on best practices for C. diff and infection management. We feel like that would be very welcome from many people, including advocacy groups such as Peggy Lillis. And we do believe that we're well aligned with the goals of advocacy groups, and specifically Peggy Lillis. And that's why we're here today, and that's why we support this foundation and feel that you're doing an amazing work every day in what you do, and we appreciate it. So in summary, antimicrobial stewardship provides a vehicle for careful, responsible management. It's really that navigation through that process. Appropriate antimicrobial use maximizes treatment benefits while minimizing adverse events. And diagnostics can help with that navigation for right drug, right dose, and duration, and hopefully minimize exposure to empiric duration, which can decrease the incidence of C. diff. Do you guys know what empiric treatment is? This is when we apply a treatment, we don't really have validation. Maybe we don't have a blood culture back, but this person is too sick not to treat them. And that's important. We have to do that. It's not done blindly, but what diagnostics can do is can say, you know what, we can go back and reevaluate that decision. Now we have more information. We can have that 48-hour timeout and say, are we doing the right thing? And should we continue it, or should we change course? And we do believe that host response biomarkers that are FDA approved for antibiotic stewardship should be considered as part of a robust antimicrobial stewardship program. And that we know that guideline and agencies are focusing on current and emerging novel diagnostics for stewardship, and we continue to support the federal efforts for antimicrobial stewardship programs. So with that, I will thank you for this opportunity to talk to this group, and really, I want to again say how much I appreciate personally what you guys are doing, and I think that my friend, Bobby and Mita Lufborough, and that Emma is Bobby's mother, are now so thankful that there is a group that's out here, and they've been on your website and are now looking to see what you're doing. So thanks again. I'm happy to take any questions if there are any. I'm sure I covered everything possible.
I just have two questions for you. The first, in your opinion, does and should weight affect dosage for antibiotics? I don't know anything about that. Because when you said a Z-Pak is given to everybody for the same duration. So that's my first question. My second question would be about infections like strep. You know, when you have strep, you get a throat culture immediately, and the duration of antibiotics, I think, is usually 7 days. In the future, would they be looking more towards getting them retested after about 3 or 4 days to see if it's negative and then stop antibiotic use?
So those are two very, very good questions. So the first is weight. And I think that is a question that could be better answered by a pharmacist. This is exactly why you need a pharmacist. And I'm not a pharmacist, but what I will tell you is it depends on the antibiotic. So because certain drugs are water soluble and certain drugs are fat soluble, so it really depends on the pharmacokinetics of the drug. So I can't really answer that, but the answer is possibly, yes, but not in every case. The second question was related to, strep. That's a really good question, too, and one that I think is important. So, first of all, why are they so fast to treat strep? Does anybody know? Because if you don't treat it, there's some really adverse things that can happen. And one of the things is that strep bacteria can't really recognize sometimes. A lot of times that it's attracted to certain areas in the body that can be very deleterious. So if an untreated strep infection, you can end up with like valve disease, so you can end up with structural heart problems that can be pretty significant. You can also end up with different things like ear problems and also renal problems. So it's really important to treat strep, and it's important to identify it quickly. One of the other things is, though, that the antibiotics can't always recognize the strep, can't differentiate a strep bacteria sometimes from, say, a cell in your ear or your kidney, which is why a lot of times the antibiotics that we use for strep have toxic effects to your ear. We could talk about ototoxicity and renal toxicity. So it is something that, requires it's a complex thing, and we shouldn't ever overlook it, even though there's a lot of strep infections. But coming back to this is a hard one, because when you talk about host response biomarkers, and a biomarker is just a signal in the body that tells you something. So, you could have a biomarker, your blood pressure is a biomarker, your heart rate's a biomarker, but in this case we're talking about lab tests that are measuring usually a protein that is upregulated or downregulated because of some sort of infectious process. So in order to measure something in the blood, it has to be in the blood. So when you talk about local infections, sometimes that is harder to do, and that's why they do have to sometimes use standard dosing along with clinical response to the treatment. And that's because a lot of times a strep infection is a soft tissue infection, like in your throat, and so you may not have any bacteria detectable in your blood, so it makes it more challenging to retest in 3 or 4 days and say, what's the response to this treatment? So they usually go more on a clinical response versus something like another test. But it's a gap. It's something we should look for and see, can we do a better job? So for the most part, these host response biomarkers work best in blood infections. So something like pneumonia, lower respiratory tract infection, usually is a systemic infection, meaning it can be detected in the serum or the blood. Does that answer your question? Good question, though. I'm always wondering, like kids and ear infections, too, but they're localized. So we have a challenge with that as well, and they get a lot of antibiotics. Any other questions?
When they were diagnosing my mom, they were trying to determine if she had C. diff or not. I don't know if this makes any sense, but they said that for the test, we had just missed the window, and they do the test in batches, so we had to wait 12 hours, actually more than 12 hours, to confirm if she had it. They did treat her with broad-spectrum antibiotics, but I was just wondering, does that make sense that we had to wait that long?
Absolutely.
It is, okay.
Absolutely. So, the lab is a big place. They have a lot going on, and they have tests that they would measure immediately on receipt of a blood specimen. But there are tests that are more run on platforms that take a little more preparation. And so they may batch them, and they may only have someone that's dedicated to running those tests at certain times during the day. And so, that is one of the logistic challenges of healthcare, is sometimes you don't have the right person or the right time or the resources, or it's cost prohibitive maybe to run a single test at a time. But for you, that was important, wasn't it?
It was, and I thought 12 hours was a long time.
Yeah. And that's not that uncommon in certain tests, especially those types of tests. So, but those are things that we need to hear feedback from patients and from these advocacy groups that, can this be managed in a different way? And these are the kind of things that need to go back to an antibiotic stewardship committee and say, we may be doing a disservice to our patients. How can we do this better? Because maybe 4 hours wouldn't have seemed near as long as 12 hours. But I feel that pain, and that is not uncommon.
Yeah. And it's not that it took 12 hours for
yeah.
the results to come back, because
yeah.
they missed the window.
Yeah.
I guess they do it twice a day.
Yep, exactly. Any other questions?
Yeah, so I just had a question around the duration of treatment. So, we've all heard the mantra, finish your antibiotics no matter what, you know, if you feel better. So I just wonder if you're aware of what kind of research is going into that. Is this more focused on the hospital setting where they can actually monitor that, or are they going back to, your strep throat treatment where, if you do feel better, you can stop treatment and hopefully stop resistance?
Is a really good question, and it's actually one of my really high areas of interest. I get so many questions about, do you have a solution for outpatient setting? How can we personalize the duration? And first of all, you have to have a platform that works well in a small clinic setting that can be run by non-credentialed, you may not have a lab technician there. So there's certain regulations by CAP and CLIA. If you want to get it CLIA waived, that takes a lot of work. So first of all, you have to have the ability to run it in the setting in a near patient way. And I think there's huge opportunity, and we need to really be looking for those sorts of solutions. But beyond that, I would say that the answer to your question is most of the data has been on hospitalized patients. I think because the access is there, the patient's there, you have the technology there, you have the physicians there. But that's a question that goes around a lot. One of the questions that when we went to the FDA looking at antibiotic stewardship is they said, what about patients who come into the emergency department but you end up ultimately not admitting them? And if you have a test that has negative predictive value and you decide that you wouldn't give an antibiotic, but this patient's already gone, how are you going to manage that? What if it comes back positive and you should have given the antibiotic? So there's all kinds of discussions that have to go on. Is there a way to manage that? Is there a way to give them the prescription and call them later and say, you do need to fill it, or you need to stop it, or there's a huge area for research and improvement in outpatient setting. I think that I have used my time, but I am happy to talk to anybody at lunch. I love to talk to everybody, and I'd like to meet all of you. Thank you.